I want to go ahead and kick us off and get us started. I'm Anissa Mitchell with PMD Alliance. And today we're going to be talking about Parkinson's and melanoma. I want to invite you to open up your chat box because we are actually going to be having a presentation, but we will take questions throughout the presentation today as opposed to holding them until the end. So feel free as Dr. Bertoni, he's our speaker today, presents something. If you have a question related to what he's asking, please feel free to give us a shout out. Hello, Ken. He's joining us from Oregon. Please give us a shout out and let us know where the rest of you are joining us from. We love learning where people are from. So please give us that shout out. And then while you're doing that, I want to go ahead and introduce our speaker today. I'm very excited to introduce Dr. John Bertone. He is professor in the Department of Neurological Sciences at the University of Nebraska Medical Center and the director of their Parkinson's disease clinic. And he came highly recommended to me from a doctor we've had on before, Dr. Oken, when I asked who could talk on this subject. And he said, your person is Dr. Bertone. So I'm so thankful to have him with us today. And I know he is going to be covering quite a bit in his presentation. So I am going to go ahead and I'm going to give this over to Dr. Bertone. Thank you for joining us, Dr. Bertone.
My pleasure. So I just want to start. Actually, if you can put my slides up, are you able to do that? Why don't we just do that? I'm very honored to be here. I do these kind of talks now and then, and it's good to see everybody out there. And I want to make this something meaningful to you. That's one of the reasons why I wanted you to be able to ask questions. If I'm not clear, or if you want more elaboration about something or less, you can tell me. So I got my MD and PhD at University of Michigan, and I have been a chairman in a department for about 20 years, Department of Neurology. And now I am still working. I really like taking care of patients. So I am going to go on to the next slide. How do I do that? Or will you do it for me? How do we do this?
All right, Sam, did you give him remote control? Okay, try your arrow and see if that works. And if not, then we'll do it for you.
You're gonna have to do it for me. It doesn't work. So yeah, why don't you go to the next slide?
All right, we're working on it. Technology is great when it works. Sometimes it's delayed.
Okay, so I don't own any of these companies, unfortunately, but I have been involved with clinical trials in a number of companies. This may not be totally up to date, and some of these have changed names, but I am not getting paid by any of them to give a talk. This is just to help you cope with your illness. Next. Okay, why are we here? What is the goal today? The goal is the best quality of life for everyone involved in this program for as long as possible, and hopefully without melanoma. Next slide, please. So when we face a problem like Parkinson's disease or melanoma, Elizabeth Kubler-Ross, somebody I've actually heard speak, talked about the stages of grief. The first response is, oh, I think they're wrong. These guys don't know what they're talking about. I don't really have something. And then when you get past that stage, you're angry about it. Why me? Why did this have to happen to me? And then you sort of bargain. Well, God, if you let this thing pass from me, I promise to be good. And then you get a little depressed, and then you finally reach acceptance. And everybody has a little different stage, and they go through it at different times. But eventually you should say, I'm just going to make the best of it. Next slide, please. So how do I fight Parkinson's disease? I look at it on the left side of the screen. These are the things that the enemy, Parkinson's, does to us. It lowers dopamine. It lowers our physical and mental activity. It may interrupt sleep. And I say, why don't we do everything to oppose these things? If we have a low dopamine level, increase dopamine by medications. Can you see my arrows here? No. Well, I don't know why we can't. But anyway.
I don't think you can if you're not controlling the slides and they're not on your screen. I think it's why.
That's okay. So basically, you have to be active. You have to get a physical therapy program. You have to take the right medications. You have to work at getting sleep. Don't watch the news at night, for Pete's sake. If you have low blood pressure, hydrate better and raise the blood pressure. If your memory isn't as good, make sure that you're not suffering from B12 deficiency or something else that's easily treatable. If you're not motivated, motivate yourself. If you don't eat well, find somebody that's going to have you eat healthy. If you like chocolate shakes, easy. Put it in a Vitamix and throw in the good stuff and enjoy it. If you have a fair skin, avoid sun exposure. Next, please. So this is a picture of the brain if you slice through like in a plane like this. And the front is up at the top. The pink and purple and blue is the middle of the brain. This is what is affected by Parkinson's disease. The outer part of the brain is what we develop when we've already developed an automatic pilot for sitting up, standing up, and walking. We learn that before you really have the outer part of our brain. So all I do, if I'm going to reach over and turn on a light switch, I stand up and I don't even think about taking steps. I just turn on the light switch. But if the automatic pilot, the center of the brain here, is affected, you don't have access to your automatic pilot. You have to take every step consciously. Next. So what is the plan? You need to learn everything you can. You learn to know how to fight this. It's a nasty fight, but you can do it. Just do the best you can and use your whole team. The question is, why are you going to do it? Everybody has their own motivation. You might want a better quality of life. You may want to be an example for your children and grandchildren. At least they can say, well, Grandpa really did a great job and wasn't he good? And he showed us that you have to exercise and you can keep yourself going even if you get an illness like this. And also when the cure comes, and we know it will, but it's not quite here yet, you'll be ready. In other words, if you're still in fairly good health, you'll enjoy it. When the vaccine, like when polio came around, everybody was able to get the shot and nobody made a mandate to make them mad. Next. So we have to pull as a team, and who is on the team? Next. So you may see behind me, I've got footballs and baseballs behind me, but you are the most important member of the team. The nurses, the therapists, the doctors are coaches. Your family and friends are your cheerleaders. Everyone else are your fans. You are the athlete, or in your shoes, I'm the athlete. It's up to me if I have Parkinson's disease. If I don't train and practice, if I don't do my part, we lose. Next. Do not let what you cannot do interfere with what you can do. So if you're having trouble, let's say when the medicines don't work, okay, that's when you shuffle papers, that's when you open the mail. When the medicine is working and you feel like doing something, that's the time to do your physical therapy. You should do it every day. I do 2 workouts a day, so I can tell other people that they should be able to work out in some way every day. And John Wooden was the coach of UCLA, as you know, many of you. Next. So I will learn all I need to know. I will listen and learn now, and I will ask questions. So please be free. If you want to use the chat and ask questions, we'll take some time in this talk to go through them. Next. So get on the right path and stay on it. So I will fight Parkinson's disease. I will fight skin cancers. There are ways to do it. And sometimes if I talk to the spouse and ask, does he or she have a stubborn streak? They look at each other knowingly and they say, boy, they have a real stubborn streak. Well, then use it. Use your stubborn streak and get even, do the best you can. So if you're going to exercise, make sure that you get the okay from your general doctor. Make sure that you're not hurting yourself. Make sure you get, one of my favorite things is if you're going to be getting physical therapy, I don't like this idea of, well, I had physical therapy, but they only let me get it twice a year. I say, you know, they're teaching you how to fish. Once you know how to fish, why do you need to be taught again? So what I say is get your cell phone out and have somebody take a movie of the therapist explaining you're sitting in a chair, you've got dumbbells in your hands, and you stand up and you sit down and you do it 10 times. And you have to be careful that you have a solid chair and nobody's going to knock you over. All the do's and don'ts, you record it on your phone. Then when the superstar, the patient, does it, you record that and you see them standing up and sitting down 10 times. And then you go on to the next exercise. And this one might be, I don't know, doing deep knee bends or maybe doing something else with the arms. And then you get the do's and don'ts, you make a movie of that, and you can watch it in the comfort of your own home, and you can do it the rest of your life, and you don't have to be reminded, it'll become second nature. But you have to start slow. You have to eat right and get a dietitian to help you. You have to sleep right. Maybe you have sleep apnea. If you're overweight, that's a possibility. Maybe if you're taking amantadine just before bedtime, that's going to keep you up. If you get up all night to go to the bathroom and you come back, you have to find a way. Some of the articles, like the article about melanoma I wrote, I guarantee you read this every night, you go right back to sleep. And it's not habit forming. So, and you have to be an optimist. You have to say, I'm going to do my best. Maybe this will be a good day. Next, please. Sometimes I sound like a preacher. So Winston Churchill, I'm dating myself, but the optimist sees an opportunity in every difficulty. The pessimist sees a difficulty in every opportunity. So you want to be the optimist. Okay, there's a silver lining here somewhere. You know, a tremor, you can say, I can sit on my hands, but it is exercise that I don't have to think about. And it's only really present when I'm not taking medications yet, or they're not in the system. Next, please. So I say if you're going to do aerobics, really start it very slow. 1 minute a day. You should do some weight training. You should work on your gait and balance. And you should do a home program every day. Like I said, make a DVD out of it. Get a younger member of your family probably that's really good at this, and you'll have it for the rest of your life. Next, please. And you don't want to give up. You know, with the pandemic, you know, nurses and doctors, hospitals have been overwhelmed. They get burned out. Well, we all get burned out. And when you start feeling that way, talk about it. Talk to somebody about it. Of course, if you liked all this crap that we're going through, we'd really worry about you. You're not supposed to like it. But you go through those stages and eventually you accept that there are some things I can't do. And you just keep on going. If you get on the right path and stay on it, keep going, that's the clue. Next. Okay, so we talked about these things. I'm going to put it up twice. Learn everything, fight this, do the best you can, and use your team. I mean, talk to people, get in support groups, whatever it takes. Next. Each person also must live their life as a model for others. Rosa Parks, who was not allowed to sit on a bus because of her color, she said she had it. You have to be a model for other people. And if people know that you're suffering, and they should with Parkinson's disease, it's not fun. Sometimes you can't motivate yourself, and it's very difficult. You have to remember, at least your legacy will be, you did the best you could. Next. James Parkinson's way back when, there are other articles about tremors going way back to Egyptian papyri, for Pete's sake, but he was the first one that really wrote this down, the shaking palsy. Okay, next. So how do we define it? How do we diagnose it? What causes it? I'll just tell you briefly, there are many causes. One thing is you may get it from a genetic cause. You may have somebody in the family with it. It may be related to environment. If you're exposed to pesticides, for example, some of those may cause it, or a combination. And then how do you manage it? You have to have the right attitude, get the right medications at the right time, get therapies, and eventually there's deep brain stimulation surgery. There's other approaches as well. Next. All right, so how do we make a clinical diagnosis? I like to make things simple, so you can put all the S's up you can think of. You're slower sometimes, you shake, but not everybody will. Some people with Parkinson's disease have an akinetic rigid form of it, and they don't have much tremor. And I've seen many patients begin up with a tremor and it goes away. And I saw a lady not too long ago, over 30 years of Parkinson's disease. She was really very conscious about her health. She was in her 60s, so she got it at a very early age. And I thought I made a mistake. I couldn't see any tremor at all. How could this be possible? She takes 15 of the Sinemet or carbidopa-levodopa pills a day, about once an hour, and something to last through the night. She exercises like crazy. But then I did see a little bit of a wiggling in the examination. And if I had her tap her feet, her head would kind of move a little bit back and forth. And I just said, I don't want to mess with your program right now, because I know that you have Parkinson's because of the tremor. And I know that you're getting enough because you're having a little dyskinesia. So you're right at the in between the dyskinesia and enough. It gets to be a smaller window as time goes on. Okay, you're stiff, and this is really, the bradykinesia is number one. That means slow movements. You don't move as quickly. That's part of normal aging, in case you haven't noticed. You have a tendency to shuffle. You take shorter steps than you want. You want to take a step this long, but it comes out this long. So the solution is try to take a step this long, and it comes out this long. So you have to overemphasize it and get yourself going. Hum a tune to yourself. That's okay. It's doctor's orders. So, and it has to be something that is helped by the medications. And it has to be the sole explanation. People can have other causes of tremors at the same time. And experts are correct only about 90% of the time, 95%. So there's a DAT scan that can tell. There's now a skin biopsy that can tell. So next, please.
Hey, Dr. Bertoni.
Yes.
I am so sorry to interrupt you, but we are getting like so many questions about the melanoma and like they're very anxious to
Okay,
hear
so why
about
don't
your
we move?
expertise.
Okay, so
Yeah.
I'm going to move quickly through these slides and we can come back if you wish. So let's keep going.
We have
Next.
some pretty good experts in here from all of these programs. So they're like so anxious to hear about your expertise in this.
Okay, all right, next. Okay, we're going to keep going. Just move ahead. So next. Next. Keep on moving. Okay, so keep going. These are some of the genetic forms. You know about these already. I want to stop at the next slide because everyone's a little different. You may have constipation 20 years before REM behavior disorder. You talk in your sleep and move around. And we'll go through this afterwards. We get through the melanoma part. Next. Keep going. Keep going. Okay, so here we go. So this is an article. I was approached by a company that was doing more research on melanomas. I wrote this article in 2010. And what we did, we had 31 centers across the United States and Canada. I designed the study. And I said, I want it so that we prove the patients have Parkinson's disease first. Then we give them a dermatology examination from their own dermatologist, whoever they want. And that's free if you're in the study. And then if you need a biopsy, according to the dermatologist, we'll make that free. So I was really working to help patients get in the study and learn what they need to know. And so then we found the best person we could up in the Northwest. And I know somebody here is from Oregon, a number of people. I think he was in Oregon or Washington State at the time. One person read all the slides, and there were hundreds of them. And then if there was a diagnosis of melanoma, you had to find somebody that could treat it. We couldn't pay for that. They wouldn't do it. I also pushed them very, very hard to have age-matched controls so we could see exactly what the difference is between so-called normal people and people that have Parkinson's. They did not allow this, and I think that's one of the shames about this. But so basically, we had 2,106 patients in this study, and they were average age about 67. And it took about 6 years to complete the study. Most people were on levodopa, and there was not any relationship to any one of the medications and melanomas that they could find. So next slide, we'll start getting into this study itself. These are all the people that we enlisted. I went to the Parkinson study group, and these are a lot of people. You probably know many of these people, but it was all over the country. I was at Creighton University at this time, and it was a very good study, one of the best ones, I think. Next. So let's have a breakdown of these people. As usual, more people were male than female with Parkinson's. There were a lot more what we call Caucasians or whites than some Asians and other. The age over 65 was the majority, about 66%. Tobacco use, as common in Parkinson's disease, we tend to be not using much tobacco. and people have asked me, oh, should I start smoking now, doc? Should I smoke cigarettes, cigars? What do you think? No, I think that's just an association. I think people who don't have as much dopamine as the average person don't take risks. They don't have a dopamine is something that makes you risky. Take chances you shouldn't, like Evel Knievel. And one of the problems with, as you know, taking too much of the medication is that you may get a tendency. I think one of the, what we call compulsiveness is dyskinesia is itself is a compulsion to move. And we don't think of it as a compulsion, but it really is. And so I think that's the explanation for not drinking so much or using tobacco. And the average duration was 7 years, but the in the parenthesis is the standard error of the mean, I think. Anyway, and then all the other agents that people used back then was 2010. So, and some of them weren't on anything. All right, next. All right, I hope you can read this. I'll explain it for you, but of the people, of the 2,106 patients, only 3% of them had a melanoma before. They had a melanoma, a malignant melanoma in situ, means it was just, if you biopsied it, it was all gone. If it's invasive, it's gone up the to the center of the body by the lymphatic system. And those are, at that time, there weren't very many good medicines that could treat melanoma that had already spread. And now there are agents that you go to a cancer specialist, and if they can eliminate all the places where the melanoma is, you may have a good life ahead of you. But you have to get found out early. And one of the main points of this is I taught you, or we've been talking about all the things you should do. I have everybody go see a dermatologist. And I picked up, I don't know how many dozens of melanomas and saved people's lives, because if you get it very early, there are some things we're going to talk about. We'll go into much more detail. But okay, there were unclassified melanomas and so on. But so of all the biopsies, 656 patients had, so that's a good, what is that? A good percentage of all these people. It's at least 30%, something like that, I think. Anyway, malignant melanomas in situ, we had 20 of them that we found in the study. So we saved lives in the study. And 4 of them were invasive. Other skin cancers that are common are basal cell cancers. And those are relatively benign, but you should get to them before they get really serious. Squamous cell carcinomas is another type of carcinoma, and those you have to get rid of. They're a little bit more malignant in general than the basal cells. And then there's other things called melanocytic Nevis. It will show some pictures of some of these. Other skin malignant neoplasm, there was somebody that had another cancer that was biopsied by a sharp dermatologist. And then there were 42 non-specific things. So the patients without any melanoma, their age was 72.6. And for some reason, with a melanoma was a little older than those that didn't have any melanoma. So the older you are and the more sunshine you've been exposed to in your life, those of you that live in Orlando and are fair-haired and fair-skinned, you have to be careful not to overdo it. the duration of Parkinson's disease really didn't have anything to do with it. The Hone and Yar score, that really is something that Doctors Hone and Yar in New York City developed a system, and that really wasn't a risk factor. Receiving levodopa therapy, 84.9 versus 82.8. And we looked at all the other agents and we didn't see any trend that looked significant at all. All right, next. So the factors that are risk factors, and in my view here, I am going to change the view because I can't see the entire slide, but I'm going to do this one for a second. So the fair complexion and blue eyes, those go together, as well as if you had a severe blistering sunburn in childhood. And, you know, in my day, we used to go down to Florida on spring break and hopefully not get in trouble. But fair-skinned people, the Caucasians, are the ones that are at high risk. Sun sensitivity, freckles, blonde or red hair, those things make a lot of sense. Inability to tan. Some people are actually have no pigment and they don't, you know, people who are albinos are really at risk. And having a congenital mole, not very much of a risk factor, and family history and so on. So the big factors are if you get sunburned and if you're fair skinned, you're likely to get a melanoma much more. Okay, next.
But is that, so if you're fair skinned, blue eyed, exposed to lots of sun, and you're at risk for developing melanoma, is that increased by having Parkinson's?
I don't think it is increased necessarily by having Parkinson's. We don't know for sure, actually, because I don't think there's ever been a perfect study in which you, because people knew this was a study about melanoma, those that were worried about their skin issues might have been more likely to enter the study. So to answer that question, this is a meta-analysis of all these studies. This is I don't know, there's a whole lot of studies here. And what I want to call your attention to, there's a vertical line, a dotted line. The vertical line is if there's no relationship with Parkinson's disease, the average, which is the bottom little diamond, that is where the average of all these studies showed that there is a little bit of a risk. It's something about 1.5 or 1.6 or 7 compared to the, so there's a little increase in the risk in patients with Parkinson's, but it may be related to how much pigment they have in their skin, and it may be just an association with that rather than having Parkinson's disease. So I want to show you, you look at the bottom of the screen that says odd ratio. If you come up, there's two little diamonds and there's a little point right here. That's where our study was. It hit the average right spot on. So this gives me some confidence that the study was not too biased, but the bottom takeaway point in this whole meeting is go see a dermatologist and have them check you out because they might save your life. I'm going to talk about this a little bit further if you want to go to the next slide. So I asked our new chairperson, Ashley Weissong, to help me out, and she gave me these slides about melanoma. Let's go to the next slide. So the new cases and deaths from melanoma, the rate of new cases is the upper green line, and it goes through about 2018. So it's not perfectly up to date. So you can see that maybe it's global warming, I don't know, but it is a little rate per 100,000 patients. There is an increasing rate of new cases. Now, maybe more people are going to see dermatologists, and the death rate appears to be improving a little bit. That's the lower thing. So the death rate, if you get it early, there's only, there's an improving death rate. So that now that we're aware of this, maybe you can get to somebody quick enough. Also, now that there are new medications available for people with melanomas, I think that's another reason for the death rate to be improved. Next. So if you look, these are from Dr. Weissong, and she's my dermatologist, and she biopsied something on my skin a little while ago, and I am very impressed by her. So if you find in the lower left here, if it's localized, it's 83% of the cases. If it's regional, that means it's spread up the arm or up the lymph nodes. Or if it's a distant metastasis, that's the 4%. It's up about 11 o'clock. And then we don't know where it comes from sometimes. It could have been somewhere else. And I want to point out, you should also see your ophthalmologist, because ask the ophthalmologist, could you really do a good, they have a slit lamp examination that they use if they're going to see, whether you have cataracts. But if you don't have bad cataracts and they can see, you want them to look all around the retina, because sometimes melanomas develop in the retina of the eye. So, and those are hard to find because you can't see them, and they're hard to be seen. You have to have a specialist look. So here are some important things about melanoma. The 5-year survival now is 93%. And I think that is increasing year by year, because now there are agents that are thought to be helping at a more involved stage. Next. All right, the trends in melanoma, there's an increase in incidence like that last slide showed, primarily among the white populations. So sun exposure and changing recreational behaviors. If you're going to go out in the sun, wear a hat. You can go golfing if you want, but don't get a melanoma or squamous cell cancer on your face. It's very common for people to get these kind of easily removed little skin cancers, but you've got to be aware that you got to do it. I worked on a golf course as a kid, and I just wore cutoffs, bare feet. I would shovel sand. I love the sun, and I have fair skin. So the lifetime risk is about 1 out of 28. So if we have 280 people, let's say at this meeting, and we have 134, let's say there's going to be 5 people in the audience that are likely to have it. And some of you probably already had skin cancers. The annual increases in melanoma varies from 3 to 7% per year. It seems to be doubling every 10 to 20 years that you live. And the cost of melanoma is over $3 billion a year. And I think that's even an underrepresentation. Next.
Dr. Bertoni, we
Yeah.
had a question before you kind of get into what these look like and some of the
Sure.
other risks. So this person said, a recent visit to my dermatologist noted that PD medications were possible for increased risk of skin cancer. And I think you sort of already addressed that, but we'll revisit that. And has the ozone layer diminished, letting more UV through the atmosphere playing a role in that?
I think it is. And I think that, well, again, do I have really, really hard proof to prove that that's it? I think that would be an explanation. If you let more UV light in, and you know, there are places now, there was protection, and now the atmosphere is a little different. You had a first question about medications, I think. I don't know, and you know, you'd have to do really good studies. And you know, when we studied, does aspirin really help prevent heart attacks or strokes? And what's the right dose? I don't know, there must have been 15 to 20 such really large studies, and we still don't know. It depends. So it's not clear, but I think things that would make you more likely to get sunburned, and some things can do that. Ointments that you put on your skin, you have to be careful. I think if you're going to go out in the sun for the first time, you should spray something to prevent the UV light to get to you. So I hope that answered those questions, or at least addressed them. Okay, so some kinds of mutations in this lower paragraph are less likely to be UV dependent. So intermittent sun exposure, superficial spreading melanomas, and there's a nodular subtype. These are strange things that are not just one color, they're heterogeneous. They may have lumps and bumps in them. And there are mutations now that people can find. And when a cancer does show up in our bodies, there's probably about, I don't know how many, could be a dozen different mutations. When a cell mutates and it gets an abnormal chromosome and all the subsequent cells are abnormal, sometimes it takes several of those mutations. That's why the longer you live, the more likely you're going to get these complicated multiple changes in your skin. The skin is a fast growing part of your body. I mean, it sheds frequently. And by the way, we used to call in a fetus what became either skin or brain tissue the neuroectoderm. So it's either the skin or it's the brain. So they're related in complicated ways. So age, and there are different types of, this is the stuff that the dermatologists know a whole lot more about. But you're right, there probably are medications. There probably are vitamin deficiencies or over medications or those kind of things that make it more likely. You know, some people used to lay out in the sun and put oil on their skin. I don't know, maybe that enhanced the risk. Next. So this shows that it's much more likely in whites than in blacks, in Asians, somewhere in between, American Indians and Alaskans in between, Hispanics in between. But you know, there's no, you know, we're all mongrels. Very few of us are totally one type of skin. Next. So this shows the cancer statistics. The darker the area, I don't know why Nebraska is in there. You would think Florida would be, or California, the sunny places, or Texas. But anyway, and it's, so you can't tell exactly where it can be. It can happen to anybody. Next slide. So genetics and environment, genetics keep going. I don't know if this keeps on adding. Yes. So basically the skin type, okay, it's been 45 minutes. The family history increases the risk sometimes twofold, especially if you have certain mutations in your genes. the number and the size of the nevi, atypical syndromes, DNA repair defects. If you have congenital nevi, that's a dark spot, or if you've had a melanoma before, those are risk factors. UV radiation in your life, intermittent intense exposure, tanning beds, sunburns during childhood, the latitude. Somebody asked about, if you're in a certain latitude, you're not going to get as much sunshine. And in fact, in most places, you don't get enough vitamin D from the sun. Somehow higher socioeconomic status, maybe they're just seeing dermatologists more often, or if you're immunosuppressed, or environmental exposures. Next. So I want you to be aware of this. You might even want to look this one up. There is a new article that just came out. It's in Movement Disorders. It's called Skin Conditions and Movement Disorders Hiding in Plain Sight. This isn't just about melanomas. It's about all the skin changes that can happen in Parkinson's disease. And I wish this were going to be made public, but it was in a journal, if you want to take notes, Movement Disorders Clinical Practice. And it was, I don't think more than, I think I was showing it to the people who are putting this on a little while ago. Yeah, it's a great article, and it talks about all sorts of skin conditions that I bet you a lot of people have. And I'm having a little trouble finding it here, but
And while
anyway,
you're looking, someone asked what atypical Nevis syndrome is.
if you go back to the picture of that brown spot, that is what we call a Nevis. So a Nevis is just kind of basically, we all have these. As we get older, we get cherry red spots on our abdomen. It's not in the lower part of our body, it's in the upper part of the body. So there are all sorts of skin abnormalities that are benign, but the ones that keep on morphing and changing their genetic makeup are the ones that get into really severe cancers. So, and there are some cancers hard to see that are, once you get them, it's already too late, like pancreatic cancer. That's one that's hard to see coming on. And retinal cancers, very few people really get a good exposure, somebody to look really for those kind of things. So a Nevis is just, I don't know the exact terminology, you can look it up in your dictionary, but it's a pigmented lesion that's just abnormal. If it's got rough edges and if it's got multiple colors in it, and if it's changing, you better go see a dermatologist. Any other questions? I'd love to answer your questions. So I think, is that pretty much the end? Oh, I want to also, if there's time, I want to point out another thing at the very end.
No, go ahead. I think you still have time.
Okay, just keep on going. So you need to get an annual dermatology exam, biopsy any suspicious lesions. I think you need an eye exam, and you have to be vigilant. You know, take off all your clothes and look at yourself and make sure that the dermatologist is looking at all your skin too. Next. I want to point one last thing out. It'll be a quick one, just keep going. One of my patients, 85-year-old man, he was my neighbor. This has nothing to do with melanoma. Oh, you got to back up. Oh, that's an okay place. He's 85 years old. He's had Parkinson's disease, let's say for 10 or more years. It was not quite that long. Anyway, his exam later showed that his mini mental status exam should be 30. It was 21. Something is going on. When I saw him again, he had loss of vibration sense and cold below the knees. In other words, he was falling before he knew he was even starting to fall. So what do we do with these people? In other words, these can be explained by just worsening of Parkinson's disease. But I had to look further. Next. He didn't show up for a couple of years, and my skin doctor or eye doctor told me he wasn't doing very well. I brought him back in 2017, and his scores were getting worse on his exam. Next. Keep going. Okay. His score was a little bit worse, but he didn't have more tremor or rigidity. He was having a lot of confusion. Next. So I decided to take the tests that he refused neuropsych testing. He got very suspicious, but these studies showed, and this is the point I want to make, when people look like they're getting worse with Parkinson's, make sure you're not getting deficient in B12. He was very deficient. You have to be at least 180. He was 72. And I said, you cannot have a low score like that, because I prescribed shots for B12 deficiency. And he said, oh, it was normal, so I quit them. Vitamin B1, which we normally used to see in my medical training, only in alcoholics that were dying out. That causes dementia. B6 was also low, which caused his neuropathy and his tendency to fall. And vitamin D, if you fall, you need to have strong bones. And so one other thing I just had to tell you is that if you lose weight, you're getting more confused, make sure that they check your vitamin B1, B6, and B12 and vitamin D. I think that way you can reverse. I had people having hallucinations, and I give them plenty of vitamin B1, and in 3 days, no more hallucinations. They're as good as they ever were. So this is an aside, but every time I give a talk on Parkinson's, I got to say, make sure you're getting good nourishment too. I think that's the end of it. Thank you for your attention. And I want to ask or answer any more questions.
Well, I had a question about what did you mean by eye exams for melanoma? So I think you brought up a really good point, but we don't even think about that. We only think about our skin, like our dermatologist reviewing us. So could you talk just a bit more about that eye exam? And
I don't think melanomas get inside our throat and GI tract. I think there's something somehow the light has something to do with them. So when you go see an eye doctor and he's looking in your eye, ask him, I'm worried people with Parkinson's disease seem to have more melanomas. Why is that? And can you check? And there may be even a way that they can enhance it by giving an injection. I don't know. But if they find something and it's tiny, boy, that saves your life. So it's very uncommon, but as long as they're looking, just say, why don't you look for melanomas, and they know how to do that. I don't know what they're going to charge you, but I would like to know. I don't want to have, when I see an eye doctor, I say, could you double check and make sure there's nothing that looks like a melanoma? I don't even know what it looks like. So.
Well, I'm glad you brought that up, because that's not something I think commonly known to even ask the eye doctor, but an easy preventative measure. So I appreciate that insight. And then the frequency of skin checks, would you say annually or even more than once a year, like every 6 months? What would you think would be appropriate for someone?
I think it depends. I think, yeah. Sometimes older people, I don't know if there's sexism, there's racism, there's also ageism. Some people say, well, at your age, does it matter? And I say, yes, I want to live another 20 years or whatever it is. And I want you to do a good job. So if they're going to be looking, I think you should get a full skin exam at least once a year. Or if they find something, they may say, I think you better come back, because I think you have pre-cancer stuff on your face, and they may give you ointments and things like that. but they'll mark it down and they'll check it the next time if they're on the ball. So on my watch, I don't want to miss things that are treatable. And I don't think they do either. And it's their job. And if they're going to do a really good job, they ought to do a really good look over your skin. And the eye doctors are the one to ask about the eye exam. I don't know how many people, I think people have told me they had a melanoma in their eye, but I don't know what the incidence or prevalence of that is.
All right, and I have a related question, but I know we're getting close to being out of time, but I have a couple of questions I don't want to not ask. So real quick, just related to the skin issue, someone wants to know if there's any connection between the loss of skin pigmentation and PD.
I think there might be. I don't know. A lot of PD patients, it's less frequent, I think. I don't know if Blacks or Hispanics or other pigmented people don't go to see Parkinson's specialists and dermatologists, but there does seem to be a connection, and I don't know if it's an important one, but it looks like it. So I think if you're fair-skinned, you're probably wise to just double check and make sure. And if you see something, you know, maybe you can even take pictures of your skin. And if it seems to change, you should point that out to your, so you can take charge. It's up to you. You're the athlete, and just ask the question.
Okay, thanks for asking that. I'm going to go back. This is unrelated to melanoma real quick. Someone wanted to know if you could explain the DAT scan real quick. What that is for those who might not be familiar with it and how that's used. Okay,
DAT means dopamine, that's DA, and transporter is the T. So in other words, if you lose the neurons in the middle of the brain, the basal ganglia, that means the middle of the brain, then it's usually asymmetric. So there's something they can just give you by your vein, usually in the arm, and that will light up when you take a certain kind of scan. And it will show you where the dopamine is, because the transporters are what bring the dopamine from your stomach, the L-DOPA from your stomach up to your brain. And that's where your basal ganglia are. And if you have it, those two parts of your brain look like commas, kind of. And if they're both brilliant and they have a lot of dopamine transporters, you're normal. If one side or both sides have a lot less than they should, and one side is worse than the other, that's typical for Parkinson's. There are other Parkinson-like syndromes, like there's Parkinsonisms, you know, that are rare. There may be, you know, other forms of Parkinson's that sometimes get treated by the same medicines, but those may cause, like Lewy body dementia, the people that have a very quick form of dementia with their Parkinson's, they may have different patterns. But yeah, it's, so if we have somebody that wants to have deep brain stimulation, we want to verify sometimes that it's the real thing. So that's one of the ways to do it. If I have somebody that has so many other problems, I wonder, that helps me. Yes, we're on the right track, but there are other issues going on as well. So does that make some sense? So yeah, you get some injection in your arm and they can see that you have Parkinson's.
And then I know we're really close to being out of time, but there's some questions about the vitamins that you were mentioning. So, and I have a couple. So one was like, are the ranges that you have listed for vitamins specific for Parkinson's, or are they for the general population?
It's for the general population, but I will tell you, if I have a borderline, let's say you have to have 180 for your B12, if you have 181 or 190, I'm going to treat that patient until they're up like 600, because like I say, on my watch, I don't want people to have problems. So a lot of people choose the wrong foods with a loss of sense of smell with Parkinson's, and that's how they get into trouble. All they want is the sweets because that's all they can appreciate. So you just have to, okay, and don't take mega vitamins because too much is bad for you. If you have a low or low normal count on vitamin B1 or B12, you had better take a little bit. But if it's normal, that's not the cause of the dementia or the other trouble you're having. So
And
too often people get more trouble walking, and it's because they have a neuropathy from these low vitamin levels. And I don't like to just say, oh, I think that's most likely Parkinson's. I want to make sure if I find something treatable, it makes my day, it makes my week, and it makes our patients' lives much better.
awesome. Well, I want to thank you so much because you brought up a lot of really good points, and the fact that Parkinson's can have a lot of different things than just the typical, and that we at PMD Alliance talk a lot about our ecosystem and all the different people that make up that system, and that medical network isn't just your movement disorder specialist, but it's also your dermatologist, it's your ophthalmologist or neuro-ophthalmologist, and all of those, because they can help with a lot of these issues. So thank you for sharing that information, and even the whole aspect of vitamin deficiency and how that can impact symptoms, and what might look like one thing can actually be
we could do another
else.
talk. We could do another talk on that, because that's a fooler, because people come in, they're not walking very well, and they say, well, doesn't that happen to Parkinson's patients? Well, if I examine their feet and they can't feel a vibration in the tuning fork that their wife can feel through her shoes, they're having a neuropathy, and it could be diabetes, it could be, but don't sit there, get up and exercise and make yourself as healthy as you can be. It's mostly in your hands. You just have to know what to do.
Awesome.
So thank you very much for your attention.
Thank you. And we have a tradition at PMD Alliance that we like to do to thank our speaker, and that is our wave of gratitude. So I'm going to invite all of our people that have their screens on to give Dr. Bertoni the wave of gratitude. And thank you so much for sharing this expertise, and for everyone joining us. And again, this will be, it's recorded, so it'll be available on the website in a day or so, as well as the slides. So you can go back and refer to, especially those things that we kind of skipped over to get to the meat of the melanoma. I know there's a lot of good detail on there, and some people can go back and review that. So please help yourself to that. Thank you so much for joining us. Thank you, Dr. Bertoni.
Thank you.
Thank you. Take care.